Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 206 of Tough to Treat. And we're motoring along. Just a brief intro to this patient. This is a patient I actually saw on a one-off visit, and she was in New York City where I practice for a business, and found me, and she had a specific reason for coming in to see me. And I think those evaluations are a little bit different than if someone is local. So she had some pelvic girdle issues, and you know, we talk a little bit about the reason why she came in and how I would sort of modify the evaluation. And if anybody has any questions, we're always putting out, if anybody wants to come on and be on the show, please email us at toughtotreatpt@gmail.com. And for those of you who are new to our podcast, thank you for joining us. And for those of you who have been loyal listeners, thank you so much for being loyal listeners. And look for some really cool stuff that Susan and I are going to be doing this summer. And for those of you who have not listened to all of the episodes, because most people don't listen to all the episodes, let's face it, is a lot. But if you have a question or some a topic that you're interested in, just type in our website toughtotreat.com in the search bar, and all the episodes with your keyword will come up. And so on to the episode. Everybody, welcome to episode number 206 of Tough to Treat, and I am Erica Mello, along with my lovely co-host Susan Clinton. How are you, Susan?
I'm good. Glad to be here. And
Yes.
remind everybody who's watching to be sure you like and subscribe. We're really trying to make sure our video gets out there, videos and audios and podcasts and everywhere you listen to us, that other people can find us.
Yes, we're on it's Tough to Treat is the YouTube channel. And you'll see us on video, and and it's interesting. When we first started, we were doing audio, and I Susan and I were face to face doing audio, and I think it comes across very differently when you're doing audio, when you're face to face. But now we're doing video, and I'm sure it'll come across even more differently when people watch the video, and you can see I use my hands a lot. So here we go. Are you ready?
Yeah, let's get to it.
Okay. So in the intro, I talked about having a different sort of perception on somebody who comes in to see you for one visit only, and someone who comes in who's local. So I'm in New York City, and a lot of people come here for whatever reason: business, pleasure, fun, etc. And I had someone come in recently who was not local. She flew in to see me, had friends here, but she was here on business, and she was one and done. Okay. And sometimes I find that hard, Susan, in the sense that, you do the evaluation, and then for me, it's like, can you help me find somebody who does what you do? And a lot of times it's hard, I know, we know a lot of people in our field, but it's kind of hard to manage that from afar, to be honest. And you can't replicate yourself. Yeah, really, clone yourself, right?
Those are the visits that I kind of couch up as consultations.
Right.
And, perhaps maybe if she does find somebody in her area, she can get on with her PT and, do a group consultation.
Yeah.
As well. I do that a lot, mainly because people aren't going to come to the Upper Peninsula of Michigan to see me unless they're coming. They should come vacation land in the summer. My God, it's beautiful up here.
Beautiful.
But yeah, so that's what I usually couch those up as consultations rather than evaluations, because we're just really taking a look at what they've done, where they've been, how they've done it, what they can do different.
Right.
So let's see what you did.
Well, yeah. So, and why are they here? And so for her, she wanted another opinion. Well, she actually hadn't seen a physical therapist. She came in for left-sided pelvic girdle pain with walking, and an extensive history, but she also wanted her thoughts on getting prolotherapy. And I'm like, they still do that? And I was like, so that's going to change how I assess it just a little bit. I do spend a ton of time on the narrative, so I shortened that, and I'll shorten it for this episode. But it was like, I'm here in New York. I have left-sided low back pain, pelvic girdle pain when I walk. Also, when she's sitting and lying on her back, or just sitting and dropping her left leg into external rotation. So just even in sitting, external rotation, supine, left external rotation, symptomatic in the glute pelvic girdle, pointing right to the SI joint, PSIS, and then with walking, with leading with that left leg. So stepping forward onto that left leg. Wanted to know, she thought prolotherapy would help her. And she was only working with a massage therapist. You know, it just kills me why people just don't go to see a physical therapist as well. It just drives me bonkers. But anyway, lucky me, she came in, and I'm going to give you her history because it's extensive. I'm going to leave out a lot of she said several surgeries in her 50s. So woman in her 50s. I'm actually going to read from it because it's extensive. 3 C-sections. Okay. Breast augmentation. So I'm like, this is the timeline. These are the early ones. Spinal fusion, T12L4 for scoliosis. I'm just going through the major ones. Thoracic outlet surgery on her right side, an abdominoplasty, a tummy tuck. Cluneal nerve resection. Let's see, skipping over left bunionectomy, thoracic outlet surgery on her left. Mastectomy and lymph node dissection right side, and then a breast reconstruction bilateral in 2023. A lot. I left out a bunch, to be honest, but a lot of surgical procedures to the thoracic cavity, to the abdomen, the breast area. You know, it's fused, right? When I saw the cluneal nerve resection, I took a double take because I don't ever think I've ever seen that. Have you?
I already have a star on here. Like, why did they do a cluneal nerve resection? I have to know. Was it because of pain?
Yep. And so I
And
left a couple.
when did she have this done? Like how many years ago?
Nine.
And she still has
The left-sided low back pain. Yeah, same side.
posterior pelvic girdle pain.
She's had the thoracic outlet stuff. She had an ulnar nerve release, which I left out. So a lot of nerve. People suggested, you know, she get like, you know, like an IgG fusion, or you know, like they were basically telling her she had an autoimmune disease based on this. Okay. And it was, you know, they also thought, you know, she threw this out there after I got the history, that they thought she had multifocal, you know, motor neuropathy and et cetera, et cetera. But she fairly active, you know, very fit individual, lean, really, you know, had many touch points, you know, before she came in to see me, but not, you know, emotional or any of that. She was just matter of fact. I get relief when the massage therapist goes into my glutes and, you know, deep tissue there, I feel a lot better. But then I go walk and it comes back. And so that was her history. I mean, I'm leaving out a bunch of stuff, but you know, for the listeners, you know, when I see kind of that history, but she's asking me about prolotherapy, I'm like, okay, well, I need to adjust the pelvis either way, right? Because she's asking me about that. That's why she's here. Right, Susan? I mean, I can't ignore the pelvis. I'm just looking through my stuff here. Oh, she also had a bunch of cortisone injections into her lumbar spine. Oh, also I left out a left high hamstring tear on that left side. Didn't do my timeline right.
I think that left hamstring tear might be significant, but they did cortisone injections where?
Lumbar spine.
Did they do any in her pelvis?
Not that I know of. No.
Kind of seems a little. How old is she? Or like the age
50s.
50s.
Yep.
And when did she tear this high hamstring tear?
I'm
assuming she tore the tendon that's going into the pelvis, into the sacral tuberous ligament.
2 years prior. So during the pandemic, 2020, 2021, I think 2022. Active, really, you know, fairly, you know, what's the word I'm looking for? She was able to, you know, she had a healthy sort of response to pain. It was like a matter of fact, like, okay, I'm here. This is what do you think? You know, so-and-so sees you and I wanted to see you, et cetera. And I was like, okay. You know, so at that point, I'm not thinking treatment. So for those of you who treat on the first visit, I absolutely was not going to do that. I could have, but I just didn't think that was a good use of my time. So I did not. So this is what I found. And so I was just like stunned by the surgical procedures, to be honest. I just was like, well, why did this happen? Why, the tummy tuck, the abdominoplasty, it's a lot, right?
Mhm.
So what I'm bringing her case up because I don't do internal pelvic floor exams. I'm not trained in that way, but I can assess the pelvis externally, and I would love Susan's insights onto other ways you can do that for the listeners who are not pelvic health therapists. I know we have a lot that are, but I'd be curious to see what you think, and I'll ask you when I give you the history here. I mean the objective. So in standing, she was loading that left side, her symptomatic side, her left side. Whenever someone says to me, I have a problem in standing or walking or squatting or whatever on one side, and they're loading that side, that raises my radar, right? Susan, why?
Yeah. Is that why
Why?
she's having problems over there, or yeah.
Right. I mean, you look at the
Why did
history.
she continue to load the side that hurts? Mhm.
Right. Right. And you look at the history, and it's right, left, right, cluneal nerve, left, a lot of stuff, a nerve stuff on her left, but she also had some right knee surgery, which I didn't mention. So it's like, if you looked at the timeline that we pulled up, that we showed up at our CSM meeting in February, she would have left, right, right. It would be, like my history, injuries all over the place, right? So in standing, she was loading her left side. Because her main movement, or the main thing that bothered her, was walking, I assessed a step forward. So that's a left step forward, with the just literally stand there, take a step with your left foot forward, just raise your right heel. I watched her walk, but for the assessment, I
Mhm.
had left step forward. She also had the issue with left external rotation. But I don't feel, you can assess that, whether it's stiff or not, or what the end feel is, but I would have missed like a lot of stuff, because if you had a priority list, it would be her entire body, her foot, her knee, her pelvis, her low back, her thorax. I mean, she's had so many things done. She didn't have any shit thoracic outlet. So the priority list is a mile long, but she's coming in to see me because, do I need prolotherapy? So I have to tell her that the pelvis is not her driver. If and I wouldn't even suggest it anyway, but that's why she was paying me. Okay. So I had to answer that question. Do you have any questions, Susan, before I
Nope,
go?
not yet.
Okay. So I'm just bringing my piece of paper here. So in standing, left thorax left over feet, pelvis left over feet, center of mass left over feet, narrow base of support, like golf, narrow. That was her natural stance, narrow. Okay, you could see the significant scoliosis. I mean, it was significant, even with the fusion. Significant, okay? Her left hip in standing was internally rotated and medially compressed. And the only reason I'm saying that is because I just put my hands on the femur. Like, I'm sort of on the side for those of you who are watching. And I just have her do a little bit of a squat, and I just see where the hip goes, whether I feel my hands medially compressing or internally rotating. You could even see that from behind. So so in standing, that was the case. When I had her do a step forward, and her do it a few times, you could see that whole left lower extremity internally rotating. So it's almost like her pelvis was in that rotation to the right, which is sort of supposed to happen when you walk. But she was loading. It was almost like if you were to put a TheraBand on the floor and had her step on it, her pelvis would be off center. It would go more to the left. So
Mhm.
when she did the step forward, she was worse. So it was almost like she was stepping, she's going around and then back over to the right. Does that make sense?
Mhm.
So, and it was
Was she
symptomatic.
actually was that the movement of her pelvis, or was she circumducting her leg?
No, moving of her pelvis.
Okay.
Yeah. And we can go into the foot stuff, and but I don't particularly think that was her driver. So I'm just going to grab my notes again. Okay. And so when someone has a fusion with a significant scoliosis, it is very hard, at least for me it is, to go in and get my hands on her thorax and decompress and try to open up one side with my hands manually. It's really difficult because that's a fixed adaptation, and that's hard to actually to correct, right? I mean, you really can't fix a Harrington rod, and it's really hard to do. But because of the abdominoplasty, the tummy tuck, and all the other the C-sections, she had 3 C-sections, one actually late in life. like in her 40s. And, no major, complications, but there's a lot of abdominal surgery going on there. And
Mhm.
in standing, she was, we've seen this before, where you could see those rib flares really tight. The tummy was really tight. It's almost like she was holding it in,
Mhm.
to make, to make herself feel better, I think. But it was her natural resting stance. Like it was almost like a protective mechanism, right? And so I want to fast forward this a bit because I'm curious as to what your thoughts are. I had to address the pelvis because that was the main reason she was there. And so um, I had her do a few other movements just because I booked the extra time. I booked an hour and a half. So because I can, and I had that extra time. And so I had her squat left. I had her step forward with the right. She was fine. I had her do a split squat with the left leg in front, right leg behind, way to the left. And so, you know, for me, it was a dominant movement pattern. And so what I wanted to do is I don't know what you think of this. I actually needed my hands free. So I have the Diane Lee's compressor belt, the compressor belt.
Mhm.
Uh, and so I put that on her, um, and tried. Diane has these, I should probably just grab one here, but she's got like straps that you can give anterior and posterior compression as well on. And so I do use that I need my hands free, and I think the pelvis is, part of her driver. And so I did put that on her, with I did bilateral anterior compression just for the audience. And she's like, "Oh, that feels great." And I was like, "Don't say that." Don't say that. I didn't say that to her, but my point is that I said, we're gonna have you repeat a bunch of tasks. I need my hands free. I need to see, the impact of optimizing temporarily your pelvic girdle with the belt to see what it looks like in your thorax, your feet, all the movement tasks. And so I did, and it was better, definitely better, not perfect. Her thorax was still to the left, but not perfect. I had her go in sitting with the pelvic belt on and had her do external rotation. And lo and behold, that was better, not perfect. So that was bugging her. She didn't care. She could have cared less if I looked at the step forward. Could have cared less.
Mhm.
Her big thing was left external rotation. So, you have any questions or should I keep going? Because
Keep
this is
going.
where I bring you, keep going. Okay. So I took off the pelvic belt and I put it aside and I had her repeat everything, repeat the step forward, repeat the squat, repeat the external rotation and sitting. Oh, she's like, "Oh, it's worse without the belt." I'm like, "Yes, it is. That's not to say the pelvis is your driver. It could be one of them because the rest of you're still gripping in your tummy, your thorax you're still to the left. It's not perfect." So with that history, and I told her, so your history, I said this, I'm 100% convinced you have more than one driver because with that history, she has to, right? And
Mhm.
so my question to you is, since I'm not an internal pelvic health therapist, but she kept pointing to like her obturate, like really going in on the ischiococcygeus and that the muscles in the deep pelvic floor. And for her, she had not seen a pelvic. She hadn't seen any physical therapist. And so at that point in the evaluation, would you have, assuming you don't have pelvic internal skills, but you can confidently assess the pelvis, would you then, based on what I've told you, go in and assess the muscles of the pelvis externally?
Yes, for sure. There's so much going on here. External rotation bothers her.
Mm-hmm.
The obturator internus is an external rotator.
Right.
So that's a big one. But the tear on the top, the hamstring connecting to the sacrotuberous ligament, it's all right there.
Yep.
I'll pull off of that myofascial tissue and the connective tissue and all of those things there. A colonial uh, uh,
Nerve resection.
resection didn't help. And I mean, that's the area of the cluneal nerve, so it's not superficial, it's deep. Um, and you said she's fairly flat, like no glute muscles or.
No, not really. Very lean, lean.
Mhm.
General.
flat, like no booty.
No, no booty.
Yeah. So that's an issue.
Yep.
Um, there's several things going on here. I wonder if it's a cross between a tendinosis and a pelvic floor that has become a pelvic complex of muscles on the left side that have become, um, do we want to use the word over recruiting? I don't know, but we can certainly use the word, tension or tension myalgia
Yep.
that can spread into that area. And, it's going to be governed every time, if you're constantly taking your leg into internal rotation, the hip angles make a difference in how that whole lower underneath pelvic complex operates.
Yep.
It should be able to internally and externally rotate.
Mhm.
The hip should be able to do both. And if one is really problematic, my question is, what's going on with those muscles for sure?
Yeah.
How are they behaving and why are they behaving in that way?
Mhm.
Probably because they're being told to. I imagine the scoliosis is probably the biggest thing that's going on with her, and you're not going to change it
No.
because they did the rod to keep it from getting worse. The rods never make it better. They just keep it from progressing. That's why they do the surgeries.
Yes.
Because, idiopathic scoliosis will continue to progress if they don't do something to halt the progression. And then when they quit growing, you just hope it stays.
Yeah.
And there's exercises and things to optimize, and the surgeries are much better than they used to be, and all of the other stuff going on as well. Um, let's see that. So the biggest thing for me would be pelvic health questions.
Mhm. Go ahead.
Do you have pain with bowel movements? Are you constipated?
Yep.
Are you leaking with walking, coughing, sneezing, laughing, climbing trees?
Mhm.
Do you feel an urge to get to the bathroom different times of the day? Are you feeling do you make it? Are you leaking some when you feel that very strong urge to go? Um, how many times a day are you peeing? How many times at night are you getting up? What were your menstrual cycles like, and what are they like now?
Well,
Um,
she didn't have any. Well, she was
right,
going through perimenopause,
right.
right? When
Well,
we saw her.
she may be into menopause now, but I would
Yeah.
want to really know what her menstrual history
Oh,
was.
prior. Yeah. Yeah.
Yeah,
Yeah. That I
because
did not ask.
if you see it, here's the thing that's getting me with her is all of these things. Was she hypermobile?
Yes.
Do you think that she was like Erlos Danlov? Like close to that type of kind of classification?
I mean, she had so many ulnar nerve. She had all these nerve
That's what
issues,
I'm
and that,
saying. Yeah.
yeah.
Yeah. So I'm just wondering if this is this is a pretty significant hypermobility type of injury type stuff going on. That tear of the hamstrings, he doesn't let this all of these things, the scoliosis.
Yep.
Do you have any medical history? No problems with her heart or dysautonia? Does she
Nope.
have any
Very.
digestion issues?
No, I asked her about digestion. She doesn't have any. I asked her about, I didn't ask her about her sexual health, and in hindsight, I probably should have. But I asked her about leaking and bowel movements, and that was all negative. I did not ask about her menstrual cycle. And yes, bear in mind, she's coming to see me for a reason and probably not expecting to hear me ask about those things, right? And so she'll
Right.
probably deny it, even though,
Yeah.
some part you're looking
I
at me
I
funny, which
I
is
question
probably
that because
exactly,
pre
exactly.
C-section abdominoplasty, uh,
Yes,
her
totally.
pressure system is completely out of control.
It's
People
just
people normalize constipation too, and so,
right.
but anyway, just looking to see what other things could be contributing to the pain along the SI and the back passage area.
Yep,
It
yep.
sounds like this is highly inflammatory. I do agree with the autoimmunity, and
Yes,
I think that
agree.
it probably got worse as she went through perimenopause, and this is
Hmm,
probably
hmm.
just having all of these different things happening,
Yep,
because perimenopause can start at, what, 38, 36, and lasts until you stop having, until you don't have a period for a year is a definition of being menopausal. um but that doesn't mean that you still don't have issues at that time. and or issues that you carried through across the fiery bridge with you are still there.
Mhm.
Um, I really feel like that this whole thing sounds to me like there needs to be some other things checked. That's why I was asking about medical stuff. I wonder what her full thyroid panel was. I Did she have cardiac issues? Does she have dysautonia? Does she like she's on the verge of like all of these things and nobody knows what to do with it. So nobody's ever really looked at her. I really feel like she needs to spend a little time in an endocrinologist's office, somebody who
Yeah.
can really take a look at the from a systems approach look with her,
Yep. Yep.
as as well, because the belt felt good, but she's has it in her brain that she's probably
Too easy.
convinced
Yeah.
that she needs stability.
Yeah. Yeah.
Because she's probably been told her entire life that she's unstable, which is not helpful.
No.
But with all the nerve, injuries and issues, did they take away a first rib? Did police on this thoracic outlet
I don't
surgery?
think so, but she's had him on both. She had him on both sides. All of her surgeries, with the exception of the fusion, were nerve related. Even the abdominoplasty and the very much, and that's why they threw out that multifocal the neuropathy. But I agree with you, in terms of the inflammatory too.
I would think multifocal neuralgia.
Motor neuro,
'Cause I don't see this person has pain. This person is not
she's
numb.
functional. She's hiking
I
and
she
exercising
has
and
pain. Well, yeah, and good for her. I mean, good for her to keep going and keep moving. I don't Here's the thing with people like this, with this kind of inflammatory, whatever this is, inflammatory, the prolotherapy is not going to do well
not,
with it.
no,
It's
no,
just not.
no. That's what I told
Um,
her. I,
I, you know, we can share articles and look it up and talk about it. But the people that I know that are the prolo experts, full body inflammation is kind of like, I don't know if something locally, regional specific is really going to adjust, this person into what they're seeking and looking for.
right. And yeah, no, I agree. I agree.
So
And
the
I think,
reason I keep bringing up the inflammatory process, the tendon tear, the nerve, kind of neuralgia things, the nerve stretch injuries or whatever we want to call them, these peripheral nerve irritations, that it's sliding across the groove, for them is painful, whereas for everybody else, it's like slide and glide all day, right?
mhm,
The reason that I keep bringing all of these things up is that it concerns me on twofold. Number one, if she's got inflammatory processes enough that's going to tear the top of her hamstring off of the sacrotuberous ligament, then how do we know that she doesn't have a tear in her, like she doesn't have a tear of one of her intrinsic ligaments in her pelvis?
right.
You
Yeah.
don't, and you add the uh, hormonal changes onto a system that's already under, or that's where the autoimmune switch turns on, is underneath the hormonal changes. Um, then that becomes, kind of an issue. I would agree two things. Number one, her diaphragm isn't working well.
Yeah.
Can't. Absolutely impossible. And I think that the pressure changes because of the abdominal surgeries and the scoliosis. If she could optimize that system, that would probably help her pelvis. But she's used to having some sort of procedure on a system when
Um,
it's in trouble.
exactly.
So, which is why she enjoys the, massage therapy. It feels good. And I don't blame her.
Yeah.
Everything hurts. Why not find something that feels good and do it? I have
Yeah.
no problem with people doing that. Is it going to right the ship? Well, it's going to keep her from teetering over the edge mentally, probably. And I think that
Right.
there's something to be said for that. Like, I'll feel good. I'll go see the, person. It helps. But, this system like this, trying to meet this system where it is what really needs to happen, and see what kinds of changes can optimize things,
Yeah.
you know,
W- w-
um, you
w-
know,
Yeah. No, exactly. Because she was loading her symptomatic side. And I was like, you can say whatever you want about prolotherapy or not, but if you continue to do that and you in a way that's not optimal, obviously when you take a step forward with your left leg, you're loading that side. But in standing and squatting across all movement patterns, she was really, her center of mass was far to the left. And I was like, look, you can get massage therapy, but you're just going to do the same thing you've always done. You need to get off your left leg. And I think that message hit home with her
Yeah.
because she was like, oh, like I never noticed that before. She wouldn't. It's normalized.
Right. And so how much she can get off that left leg is going to be highly dependent upon how rigid her trunk is because of the Harrington rod. So those have to be optimized,
Yeah.
and to give her some room
Some
in which to,
salsa.
yeah, into which to move and to do things. Quite frankly, until things can get better, if she's going to work on this, I wouldn't be opposed to her putting a belt on if she was walking
Yeah. Yeah.
and it helped her feel better.
Yeah.
Like, if it makes you feel better, pop it on while you go walk. You don't have to wear it all day long.
Agreed.
Don't wear it all day long. Just pop it on when you go walk if it feels better,
Yep. Yep.
Buy a nice pair of compression underwear and see how it feels.
Mm-hmm.
Like, something that maybe will hug the area a little bit just to give
Mm-hmm.
give the sensory system the message that I've gotcha.
Yep.
That's the only reason tape works is because of the sensory,
But
system
yeah.
input that comes
Yeah.
from that.
Yeah.
So, but she still needs to work on optimizing kind of her center of mass as good as can be done in this scenario. But I would also probably venture to say because of everything that's gone on and all of these things that has happened, is her balance system is also pulled to, her balance system is keeping her there.
Yeah. Yeah. For sure. For sure.
And so that has to be dealt with too. And it
Yeah.
probably, all of this thoracic outlet and ulnar nerve, all this input up into the head and neck, besides everything else. Yeah, this is,
I mean, just based on the history alone, you could just we talked about this, make a deduction or make a clinical hypothesis. But with
mhm.
her, it was just, she's like, well, the massage makes me feel better. I said, but if you get up and load that left side, it gets tight again. And it's just like a vicious cycle. It's like you spend money and you feel better, but then it goes back. And
No better, but do something about what's causing it.
right.
Yeah.
And so I think so I have one question for you. So getting her aware of that was, I think, the major eye opener for her because she had no idea. And she's, one of these people who's very, intellectual and aware
Yeah.
of that.
Mhm.
And once she realized she was loading that left side, she was doing her darndest to really focus on, not doing that. However, based on the abdominoplasty, the C-sections, all the abdominal surgery, she needed that salsa, that breath work in the diaphragm. And I didn't get into treatment with her. This is what I was saying at the beginning. My evaluation is very different. Not very, but it has nuances when I'm being asked a question and the person's not coming back to see me.
Mhm.
Right. Versus someone who's I'm going to continue with here in New York. So with her, did I talk about diaphragm? No. But if she were here, I would have. Right.
Mhm.
I mean, she came at me with one question and I was like, you don't need prolotherapy. And I gave her my reasons. And, your pelvis, I don't think is your main driver. I mean, you ultimately, if you want to get prolotherapy and you load that left side, you've wasted your money. That's what I
Mhm.
basically said to her. But the only way to get her off that left side was to, get the breath work, get the diaphragm moving, get everything down. But I didn't have that luxury.
Right.
But my question to you is, because she was really hung up on this external rotation piece in sitting. Excuse me. And she kept showing it to me. And I'm like, okay, well, this is something I have to address. So I, know the anatomy of the pelvic floor. And I went in, I sort of, did my assessment, extremely tight there. For those listeners who don't do this externally, I had her in side lying. I had her in supine with her leg over my shoulder. You know, are there
Mhm.
any other ways that you could do that externally for the non-pelvic health therapists out there?
You can do it sitting and just slide your hands up underneath.
So sitting with
Slide
that's,
telling that I'm coming up right next to your anus and your vagina. I'm just gonna be cuddling up right next to them through their
yeah,
clothes,
yeah.
and you can feel what's going on in there, and you could have your hand there hooked up underneath the left side and
Mm,
have her internally and externally move her leg. Because what I
mhm,
would be looking for there is in sitting,
yeah.
does she abduct and adduct as she does external rotation? Or can she
Um,
keep her femur still and just roll it? Like
right.
that can tell a lot
Yes.
as
That's
to what's happening, there. Can she control it? Can she move her femur without moving her pelvis? We should be able to do the 2 separately.
mhm, mhm,
So that's be
mhm.
beautiful, but we should be able to um, lift our knee up without the pelvis rocking backwards. We should have room for that. We should
Yeah,
be able to internally and externally rotate the pelvis with the femur actually doing the rotation, not this kind of thing going,
right,
sliding
like
back and
rocking.
forth.
Yeah.
Um, and that gets into a lot of the work, with Shirley Sarman and
Mhm.
others is really helping somebody like her, like in prone. Can she hold her pelvis still? And what happens when she rotates?
Yeah, and disassociate.
And is it rotating, the femur rotating, or is it sliding into abduction and adduction
Right.
in that position? So what does it look like with the femur extended? What does it look like with it flexed? Um,
Yep, yep,
and
yep,
yeah,
yep.
and just checking those things because that'll tell you a long way into, okay, how can we get her to motorically change this? And why is this doing this? Is it because it's a mass pattern of movement that has been built into her system?
Yep.
Can she break it up? And can we work it into a different way? And it may be because of the way she's being pulled with her scoliosis forever,
Yeah,
that that movement pattern has always been set up there.
yeah, yeah,
And it bothers her because it
yeah.
hurts.
Right. And I think that, we talked about a lot about what set them up, what kept them there with her. She had so much, and you lump them into neurosurgeries and by sort of like, joint surgeries. She had a lot. And I do think the high hamstring tear, which was more recent, actually was relevant in this case, in a very sort of focal way. Because, when I saw that history, I was like, oh my gosh, and I didn't even tell you half of it. There's a lot, and Ehlers-Danlos as well, I think possibility. But you
Or
don't
maybe
know at
it's
this point.
respect, some people just don't fit the boxes there, but they're not on the other side of the connective tissue, place either. She's still
Right,
Gumby.
right, exactly. And because of her hang up with that external rotation, that's why I did that and I had her sideline. I like just doing it in supine. That's a great idea, or sitting.
Mhm.
Um, because she was just like, can you feel this? I mean, she was very like adamant about me. Here, I'm going to put your hand right where it hurts type thing. And I had to, debunk that. I think that possibly was relevant, to be honest, because she did feel better with that. And so I said, don't get the prolotherapy because if you want, you need to change your strategy first and you need to do a lot of other things. So she left New York, went home, I emailed her. In that email exchange, I talked about breath work. I said, okay, I can do a little bit of this, virtually. I talked about some breath work, working with the diaphragm. And I said, you need to be really aware of your left side. She went back to the massage therapist, and I think he did some work a little bit deeper based on some of the suggestions that I had. He was just doing like superficial piriformis, I'm assuming, and it did very different positions. And I said, you need to check your external rotation pre and post. I need you to stand up and see if you, after that release, if you're more centered. And she did. And then so about a month or two went by, and I emailed her again, and she said to me, I'm not quoting, but it was pretty much what she said. She said, um, the one thing that was the most, after all of this, that was like the most helpful, was making her aware of her strategy on her left side, that she was loading that left side so much that it was a perpetual pain cycle. And then she said that, because I used the word salsa, I said, we need
Mhm.
to get more salsa. And because of her abdominal gripping, uh, I'm like, you need to like, I had her on all fours. I'm like, let your belly go, let your belly go. No one's here, just let it go. And in doing that, I had her do that at home in where she lived. And that also helped. And so I think the main issue for her was being aware, not
Mhm.
necessarily like a specific treatment intervention was being aware of that strategy. And, and, you know, I mentioned this because I looked at that history and I almost lost it because
Yep,
that
and
was
that's where
so much.
with complex people, the more simple we can make it, the better. She
Yeah.
told you everything she needed to know.
Yeah.
She wanted you to look at this piece, she wanted you to look at that piece, and she wanted to know, was this other thing gonna help her? And the belt helped her.
Did.
Okay, so
Uh,
because compression makes her feel better. Got
Yes.
it.
Yeah.
So get off your left leg. Let's see how that makes you feel.
Yeah. Yeah. And I
Yeah.
offered to taper too, but I was like, you're not coming back. So, but she did wear, I had suggested like, Spanx, and
Yeah.
she was like, I actually felt better. And I was like,
Yeah.
okay,
She likes the compression. Go for it. I'm for it. If it helps them and it makes them feel better, I don't care if it's placebo or not. I've nocebo I don't
Agreed.
want. And she's had a lifetime of nocebo.
Yeah.
Like you have bad tendons, you have bad this, you have bad that, you've got this, and I mean, that's a lifetime of that type of input. You
Yeah.
know, she got a good strategy. It was really nice for her to have something very simple to be aware of. And oftentimes those simple things can change the environment way more than being real complicated. And for someone like her, you got to find one place to start working.
Yes.
Um, if this had been somebody I had seen and I was going to be able to treat them, I would have left the pelvis alone and said, let's figure out how to get your trunk to get you lined up on, over both legs.
Agreed.
Let's do some strategies and some work for you to be like deload that left leg a little bit. Like, where are you standing on your feet and how much can you like just shift slightly on
Mhm.
your feet? And how does that make you feel all the way up the chain? And do we need to do some balance work in that position? What do we need to do? But when you only have one thing to do, I think you've got to address what it is that they want, because you couldn't have given her like a laundry list of exercises. First of all, she wouldn't have done them. Second, because they weren't relevant.
She would still have the
Secondly, there's no
question.
follow-up, so it's not really that safe for her,
No.
probably in her brain.
Yeah.
But what was good was that, like, don't take away the one thing that they have that they love. Just
Mhm.
explain to them, like, the it's great that this helps. However, it's not doing anything to change it in the long run. So you're loading on your left side. We've got to figure out how to keep you from loading so much on the left side all the time.
Yeah. Yeah. Yeah.
And, the vicious cycle, and that probably raised her awareness more than anything else, because she feels better when she gets off the table. Strike while the iron is hot. Start doing some of this stuff over on the other side.
Yeah. And,
Like,
and
check yourself with your movement and your things and see if, even in sitting, what if you just like shifted to the right side? I don't know. Would that help that little external rotation, whatever thing is going on? But
very
just
true.
playing with it and letting her kind of come up with the strategies, she'll probably find some better than, if somebody was like nitpicking every little piece on her body. And I think that's what happens with clinicians out there is people come in and they have
Yeah. Yeah.
a
Yeah.
lot going on, and so do we. I mean, we're not exempt from any of this, but it scares people. It does. It scares people, and they don't know what to do, and they have this burden, this mantle of burden on them that I've got to fix this whole person. It's like, no,
No.
meet them where they are, find out what the priority is, start there.
Agreed. And
Make it relevant to what it is that they're concerned about. Whatever it is that you're doing, be sure that the client sees the relevance of what this is, how this is going to affect this area that they're, and once you start doing something, the way our systems are, everything touches everything.
and
So
also
who knows that this strategy of her getting onto the right side may start changing some other things for her.
exactly.
It may help her pain, but it may also start changing some other things for her too. And
Yeah.
her awareness will change, and then maybe she'll bump up to the next level of like, okay, I'm ready to tackle this piece on. Maybe I am holding my tummy too tight. Who knows what may come out of all of this?
Yeah.
But
But
Mhm.
yeah, no. The reason I wanted to bring her up because I did use the pelvic belt, and I don't see a lot of pelvis drivers, but I will tell you that if she were here and I continued, I still would have, I used that, I used Diane's belt basically if I need another set of hands. And so if I'm trying to center her with manually with through the pelvis, and I'm doing different, manual corrections to her pelvis, and she's moving better. I use that belt I don't want to say fixate that, to support her in that optimal position. But if I had seen that belt made her, her trunk rotation worse, her head worse, her feet or whatever, or step forward worse, her squat, I would have taken it off immediately.
Yeah. Yeah.
I needed that. I needed my hands free. And so for clinicians, who pelvic or non-pelvic health therapists, it's a great way to assess the impact of treating the pelvis on the rest of the body. Like Susan said, it's all related and connected. And so if you treated the pelvis and her head was worse, let's say her head was worse, like her head rotation was worse, or she felt really off, she would have come back the next visit and not felt so good, right? And so I like to use that belt because I had to answer the question: is the pelvis the driver, and does she need Prolo? Period. End of report. That's the question. If she walked out of there and didn't have the answer to that question, I would not have done my job. And so that's the reason why I wanted to bring her up too, because of just in terms of assessing externally the pelvic floor, and also answering the patient's questions for people who do come in who are just these one type of consult, like you were saying, consultations. It is a different process, I think, in terms of the evaluation. Could I have spent a ton of time doing breath work? Absolutely. But I don't think would have been worth it for me in that first visit, because I think she wouldn't have gotten her questions answered. So, I think that's it. Any other
Nope.
comments, remarks?
Nope. This was good. Thanks.
You're welcome.
All
So
right, everybody.
you enjoyed it.
If you're on YouTube with us, like and subscribe. If you're listening to us on your favorite platform for podcasts, be sure you leave us a review. The more reviews we get, the better it is for people to find us.
Yeah,
And we would love for people to join in and be part of it. And this podcast is for you.
Yes, and if you have any questions or want to put comments in on the YouTube, if you're watching us on YouTube, feel free. We're not getting notifications of comments, so we're going to try and see if we can fix that. So if we don't answer, apologies ahead of time, but feel free to do that. And if it's an easy way to make a comment or ask a question, I'm happy to do that as well. So thank you, and we'll see you in the next episode. Bye.